Start.
Good evening, everyone. I am Rajendra Arora. On behalf of Hetero Healthcare, I welcome you all for this webinar. Hetero prides itself for being one of the few pharmaceutical organizations that has on a robust research and development program. Hetero is having 21 years of expertise in pharmaceutical, 25 plus state-of-art manufacturing facilities, presence in more than 120 countries, 15,000 plus across globe, and 200 plus products in portfolio. Largest privately held pharmaceutical company in India. Rectal Research Foundation started as early as in the year 1995, spearheaded by more than 500 top-notch scientists. Excellence in developing generics, difficult to make, and complex APIs, novel drug delivery systems, new chemical entities, and biosimilars. Hetero Healthcare is one of the world leaders in developing and manufacturing a wide range of brands in various therapy segments, including gastroenterology and hepatology. More than 3 decades of expertise in manufacturing and marketing pharmaceutical, Hetero Healthcare has also been at the forefront for providing drugs for COVID-19 pandemic, such as the COVID-4, which is the brand of Remdesivir, and Favipiravir, the brand of Favipiravir. Hetero Healthcare is committed towards creating awareness about hepatitis B and C, along with products like Heptivite provides access to high-quality medicines at affordable rates and enriching lives of patients for better well-being. Adding to the portfolio, we are pleased to introduce Midohep, a brand of midodrine hydrochloride, a vasoconstrictor being widely used in orthostatic hypotension and various secondary hypertensive disorders. It has been recently shown to have a significant improvement in cirrhotic patients with ascites. Also, we are pleased to introduce Atlant Suppository, a brand of indomethacin to be administered rectally, and pancreatitis is a common and severe complication of ERCP. Various studies have shown efficacy of rectally administered indomethacin in preventing post-ERCP pancreatitis. For further detailed discussion on the topics in our today's webinar, role of midodrine hydrochloride in managing refractory ascites and prevention of ERCP-induced pancreatitis, I would like to introduce our moderator and speaker. We have with us our moderator, is Dr. Ajay Kumar Jain. I'm just, Senior Consultant and Director of the Department of Gastroenterology in Chaitram Hospital and Research Center in Indore. He has worked as a Senior Research Associate at GB Pant Hospital and RML Hospital, New Delhi. He was awarded fellowship in a clinical observer in the Advanced Therapeutic Endoscopy Training Program at Beth Israel Deaconess Medical Center, Boston, USA. He was instrumental in starting the first postgraduate DNB gastroenterology teaching program of Central India in 2006, and he has been running it successfully ever since. He was governing council member of the Indian Society of Gastroenterology from 2017 to 2020, and currently he is serving as a treasurer for the society. He was organizing secretary of 56th National Conference of ESGE, which was held at Indore, Madhya Pradesh. He has around 35 publications in peer-reviewed journals. He has been awarded with Har Gobind Foundation Medical Fellowship in 1998. I welcome Dr. Ajay Kumar Jain. And the first speaker we have, the topic is role of midodrine in managing refractory ascites. We have Dr. Praveen Sharma. He is a consultant gastroenterologist in Gangaram Hospital, New Delhi. He has worked as senior resident and senior research associate in the Department of Gastroenterology, GB Pant. He has worked as a fellow hepatologist in liver transplant unit hospital, Paul Bus Trans. The hospital has done more than 2,500 transplants and is recognized for its expertise for transplants in co-infected patients of HIV, HBV, and HCV, and Paul Bus transplant. He has done an advanced endoscopy course in Kyushu University, Fukuoka, Japan, and observed LBI, ESGE, EMR, and cholangiopancreatography. He has more than 130 papers publication to his credit. He has 6 chapter publications in gastroenterology and hepatology books. He is being awarded prestigious Om Prakash Memorial Award 2011, SR Naik Award in 2012 by Indian Society of Gastroenterology. He is reviewed for various journals including Gastroenterology, American Journal of Gastroenterology, Journal of Hepatology, Liver International, Indian Journal of Gastroenterology, Turkish Journal of Gastroenterology, Journal of Clinical and Experimental Hepatology. I welcome Dr. Praveen Sharma. We have a second topic of our webinar is prevention of ERCP-induced pancreatitis. We have speaker Dr. Kunal Das. And Dr. Kunal is the head of department and consultant in Department of Gastroenterology, Manipal Hospital, New Delhi. He has various fellowships and memberships of organizations such as American Society of Gastroenterology, Endoscopy, Indian Society of Gastroenterology, Indian Federation of Ultrasound and Medicine and Biology, European Society of Gastroenterology, Endoscopy, Indian Medical Association. He was Vice President of Association of Physicians of India, API, which is of Untitled Chapter. He has received various awards, including Travel Award for presentation at Second International Symposium on AIPD and Cirrhosis, Japan. Fellowship of Japanese Society of Ultrasonic in Medicine, Young Investigator Award at 50th Annual Meeting of Asia Pacific Association for Study of Liver in Bali. He has area of expertise are diagnostic and therapeutic procedures such as endoscopy, ERCP, EUSN, and Endoscopy. So I welcome all of our moderators and speakers. And now I just hand over my session to Dr. Ajay Jain to take it further, sir. Dr. Ajay Jain.
Good evening, friends. It's indeed a matter of privilege for me to be part of this important webinar. Today, we are going to discuss two very important clinical topics which are relevant not only to the gastroenterologist, but to the physicians and surgeons as well. And they are the one which we see day in and day out in our day-to-day clinical practice. To discuss these two important topics, we have two eminent academic gastroenterologists of the country who will be dealing with these topics. And then we will have a live question answer session where we can be able to solve few of the questions raised during the talk, or few of the confusions or questions which you have in your mind. You can get these questions solved by these two eminent gastroenterologists. The first topic is role of midodrine in managing refractory ascites. With the prevailing corona call and then changing lifestyle, the prevalence of chronic liver disease, especially because of alcohol and non-alcoholic fatty liver disease, is increasing. And most of these patients, when they come for the first time, they come with a decompensated liver disease. And the refractory ascites are one of the most common complication of these diseases, where we have to face a lot of challenges. So to deal with the newer management options in the management of refractory ascites, we have none other than Dr. Praveen Sharma, who is a par excellent academician with 130 paper publications in peer-reviewed journals and 6 chapter publications in gastroenterology and hepatology books. He will be discussing with us the role of midodrine in managing refractory ascites. Dr. Praveen Sharma, please.
Thank you, Dr. Ajay, and thank you, the hetero team. So I will be discussing today the role of midodrine in managing refractory ascites. So we can classify cirrhosis into 4 stages: stage 1, 2, 3, and 4. Stage 1 is characterized by when the patient has cirrhosis, but he has no ascites and no esophageal varices. So these are the patients who are just like a normal person, and their mortality rate is less than 1% per year. Then the stage 2. Stage 2 is characterized by when the patient has cirrhosis with varices, but there is no ascites. These patients also live longer, but their mortality, that is their chances of death in a year, is about 3 to 4% per year. We have stage 3, which is characterized by presence of ascites. Once the ascites has come, it means the patient has now decompensated. It means the stage of the cirrhosis have increased. These are the patients who have a high mortality, that is they die, that is 20% per year. So the formation of ascites is an important step in the natural history of cirrhosis. Then the stage 4, which is characterized by decompensated liver disease, which is characterized either by esophageal bleeding with or without ascites. So these are the patients who have a high mortality over a period of 1 year. Now let us see what is the natural history of ascites. Once the patient has cirrhosis with portal hypertension, but there is no ascites, it means that the portal pressure in them is normally less than 10, and there is minimal splanchnic vasodilation. Once the patient has developed ascites, which is uncomplicated. When I say uncomplicated, it means there is no SBP, that is the infection of the peritoneal fluid, or patient whose ascites can be controlled easily by diuretics. That is, it is not uncontrollable by diuretics, which is called as uncomplicated ascites. In this patient, the portal pressure is though high, which is more than 10, and there is a moderate splanchno-dilatation of the splanchnic vasculature. Then comes the refractory ascites, which we are dealing with. Refractory ascites is a complicated ascites, which is characterized by when the portal pressure is more than 10, and there is severe vasodilatation of splanchnic vasculature. Then the terminal stage of the liver disease, when there is a marked extreme vasodilatation, these patients of refractory ascites are complicated by renal injury, which is called as hepatorenal syndrome. So this is how this is a natural history of ascites. So ascites could be because of two hypothesis theory. One is known as the underfilling, and the second is the increase in the splanchnic capillary pressure. So in the cirrhosis, there is a portal hypertension when we call the HVPG is more than 5. There is a splanchnic vasodilatation. This is the characteristic steps of cirrhosis patient. Splanchnic vasodilatation can lead into two things. One is the arterial underfilling, that is most of the blood remains in the splanchnic vasculature, and there is an underfilling of the systemic vasculature, which is characterized by activation of various vasoconstrictor systems and antinephrotic factors. This is the main step in the formation of ascites and the complications of cirrhosis. Once there is an activation of these vasoconstrictor agents, they cause sodium retention through the kidneys, they cause vasoconstriction of the kidney vasculature, and thereby they causes the sensation in the body that you need to store more of water, which leads to ascites formation. Similarly, if there is a splanchnic pressure, there is a high in the splanchnic pressure, there is more of lymph formation than the lymph returns, which itself can lead to ascites formation. If we know this, the pathogenesis of ascites, then we can control this by using various diuretics and the sodium restriction. We need to understand what is the pathophysiology basis of cirrhotic ascites before we can go on the refractory ascites and the control of ascites. On the x-axis, this is the time in years, and on the y-axis, there are changes which were followed in patient of cirrhosis. Initially, when the patient has compensated cirrhosis, which means patient has no ascites, no varicose bleeding, no hepatic encephalopathy or jaundice, then this curve, the red one, is known as the cardiac output. In the initial phases of the cirrhosis, the cardiac output almost increases, but in the terminal stage, when the patient has decompensated, this cardiac output decreases. Similarly, the systemic vascular resistance, initially it reduces and then it keep on reducing once the progression of the cirrhosis. And the splanchnic vasodilatation, it started increasing from the compensated stage to the advanced stage of the cirrhosis. So what does it mean? That in the patient who have an advanced cirrhosis, there is a decrease in the cardiac output, there is a marked splanchnic arterial vasodilatation, and there is a reduction of the systemic vascular resistance. So this three pathogenesis process causes increase in the degree of activation of various renin-angiotensin aldosterone system pathogenesis, systemic nervous system, and antidiuretic hormone release. So this is the pathophysiology of formation of ascites. Thereby, stimulation of this pathway leads to stimulation of the kidney and absorption of more water. So how do we treat ascites? We are dealing with ascites who have a high SAG ascites. If the patient is taking alcohol, one should always stop alcohol. If the patient has other treatable liver disease like hepatitis B and C, one should try to treat those. Then we can control the ascites. If the patient has significant portal hypertension, the use of salt and diuretics should be used. One should always identify some precipitating factor which can lead to ascites. If you can reduce that, if the patient is taking extra salt, try to reduce that. If the patient is not taking diuretic, one should try to compliant the patient so that he can take more diuretics on the regular basis. If there's a GI bleeding, stop it. If the patient has developed SCC, then these are the patients who can go into the refractory stage of the ascites. If the patient is taking non-steroidal anti-inflammatory drugs or maybe some antihypertensive like ACE inhibitor, ARB inhibitors, try to reduce those because these are the drugs which can complicate your control of ascites. So treatment of ascites as a general principle includes salt restriction, which is the mainstay of treatment in every form of ascites, either it is complicated or uncomplicated. One should try to reduce the salt intake to 2 grams, which corresponds to about 5 grams of common salt in our day-to-day practice. Low salt normally can eliminate ascites in about 10% of the patient, which is normally ascites which is grade 1. then how do we know that patient is taking adequate amount of salt and patient is compliant to your diuretics? We can check urinary sodium excretion, which is in clinical practices, nobody does that, but one can check the urinary sodium versus potassium ratio, which can be done easily in the clinics also and in the lab. If it is more than 1, it means that the patient is probably compliant to your salt restriction and diuretics. So the topic of discussion today is refractory ascites. How do we define it? According to the International Ascitic Club criteria, ascites that cannot be mobilized or the early recurrence of which cannot be satisfactorily prevented by medical therapy. So this is known as refractory ascites. It can be divided into 2 categories. One is known as the diuretic resistance and the second one is diuretic intractable. In clinical practice, most of the patients, they have diuretic intractable ascites, which we call as refractory ascites. What is diuretic resistance? Diuretic resistant ascites is defined as ascites that cannot be mobilized or the early recurrence of which cannot be prevented because of the lack of the patient to adequate amount of diuretics. We will discuss what is adequate amount of diuretics. And the diuretic intractable is ascites that cannot be mobilized or the early recurrence which cannot be prevented because the development of diuretic induced complications that preclude the use of effective diuretic dosage. So these are the 2 types of refractory ascites. One is diuretic intractable, which is more common than diuretic resistance. So how do we define these criteria? When we say treatment duration, how much diuretic to be used and for how much duration? So patient must be on intensive diuretic therapy. When I say intensive, it means the furosemide should be used to the dose of about 160 and spironolactone to the tune of 400 milligram. But we all know that most of the clinicians, they do not use this much of high dose of diuretic because Indian people, they do not tolerate it. But this much of medicine should be used for at least 1 week and patient should be on salt restricted diet. So this is known as the treatment duration. So before defining refractory ascites, one should give this much of high dose for at least 1 week. Then when we say the patient is does not have any response, if the weight loss is less than 0.8 kg over the next 4 days with this much of intensive therapy, then we say the patient is not responding to your drug therapy. If the patient is responding, but there is a reappearance of grade 2 or grade 3 ascites. When I say grade 2, it means that patient has a moderate ascites, and grade 3 means patient has a tense ascites. Within 4 weeks of initial mobilization, this is known as early recurrence. And when we say diuretic induced complication, what does it mean? It means the patient has developed either because of diuretic therapy, patient developed hepatic encephalopathy, patient has got renal impairment, his creatinine value is more than 100% of his baseline value or a value of more than 2 milligram. Patient develops hyponatremia, that is less than 125 millimoles, or that is the serum sodium decreases more than 10. Patient either developed hypo or hyperkalemia, or patient develops significant muscle cramps. So because of these complications, we cannot use diuretic to the tune of about 160 of furosemide or 400 milligram of spironolactone. This is known as diuretic induced complications. So what are the management principles of refractory ascites? One is the medical therapy, which we all know that salt restriction, adequate amount of fluid, and the diuretic dosage. If the patient is not responding to that, we do large volume paracentesis, which is tapping of ascitic fluid to more than 5 liters, or the complete paracentesis. If the patient is still not responding that, or they were recurrent ascitic requiring recurrent LVP, TIPS is the therapy. The definite management principle is a liver transplant. If the patient develops refractory ascites, then the chances of his survival in the next 1 year is less than 30%. So any patient of cirrhosis with refractory ascites is a transplant candidate. One should always ask this patient to undergo liver transplant as early as possible because his survival chances is less than 30% over a period of 1 year. Then there are other medical therapies which we are going to discuss. And if patient is not able to there is no other options, then the palliative therapy with repeated large volume paracentesis is the only medical means which we have. So the initial treatment principles is look for his drugs. If the patient is taking ACE inhibitors, receptor blockers, or NSAID, that should be stopped. Try to, there is a good study which has shown that if his systemic blood pressure is more than 82, these are the patients who have a good survival vis-a-vis those whose systemic blood pressure is less than 82. So the newer therapy which are used for the treatment of refractory ascites try to keep the mean arterial pressure on the higher side so that the patient responds better to diuretics. Then salt intake should be strictly monitored, and diuretic should be adequately implemented in these patients to the extent that they can tolerate this without any intolerable side effects. Step 3 is very important. If the patient is taking some beta blockers, so there is a controversial issue whether beta blockers should be given in patients who have a refractory ascites. But if you want to give it to the lower dose, and propanol is better than carvedilol in patient of refractory ascites. And propanol should be used, if at all, to the lower doses, that is less than 40 milligram in most of these patients. Carvedilol should be avoided because they have an additional vasodilatory effect of against anti-alpha-1 receptors. Third, normally we try to titrate the heart rate to about 50 to 55, but in this patient, this target heart rate should not be achieved because they have a low BP, and if you target with a high propanol, this patient will develop more ascites and refractory ascites. So according to Baveno guidelines, Baveno 6, beta blocker should be avoided if the systemic blood pressure is less than 90, if the creatinine is more than 1.5 and patient has severe hyponatremia, then they should be used with caution. They should not be avoided. There is no guidelines which say they should be avoided, but they should be used as low as possible. Now the topic of discussion is midodrine, because this baseline data is important before we jump into the midodrine use. So midodrine and its role in refractory ascites. So what is midodrine? Midodrine is alpha-1 agonist drug, and it is a prodrug. It gets metabolized in the liver to its active metabolite, which is known as desglycomidodrine. The half-life of midodrine is about 25 minutes, vis-a-vis its active form, that is desglycomidodrine, has a half-life of 3 hours. Why this 3 hours is important? Because then the dosing principles of midodrine is based on this half-life, that it should be given on 4 to 6 hours interval. Midodrine gets metabolized mainly by the liver, and I just want to say that till now, though midodrine has shown to be safe in patients who have cirrhosis, but it should be used with some cautions in patients with cirrhosis because it gets metabolized in the liver. It has got insignificant renal elimination by midodrine, but desglycomidodrine is excreted by the renal. So if the patient has got renal dysfunction, the use of midodrine should be used with very cautiously because its active metabolite gets eliminated by the midodrine, by the renal route. So midodrine is a prodrug which get into this active metabolite desglycomidodrine in the liver, which acts on the alpha-1 receptor agonist. How does it act? It is a vasoconstrictor, so it increases the tone in the systemic vascular resistance, systemic vasculature, as well as in the splanchnic, leads to splanchnic vasoconstriction. Thereby, it improves systemic circulation. Once the systemic circulation increases, it also improves the renal function. Once the renal function improves, it causes increased sodium and water excretion, and there is a more improvement in the ascites formation. So this is how the way of acting of midodrine. The dose of midodrine should be started from 5 milligram 3 times in a day and should be increased to the tune that we achieve a mean arterial pressure increase of more than 10 over a period of about 5 to 7 days. Midodrine must be taken during the day. Why? And at the interval of about 3 to 4 hours because of the plasma half-life. It should be avoided in the late night because sometimes it can cause supine hypertension. So the last dose of midodrine should be at about 6 or 7 o'clock to avoid supine hypertension. So there are various studies which have shown that the midodrine, if used in conjunction with the diuretics, is more able to control the refractory ascites. This is an important study published from the Egypt. In American Journal of Internal Medicine, they have taken about 90 patients, out of which 71 completed the follow-up part. Out of this, Group A and Group B, Group A received a standard medical therapy. When I say standard medical therapy, it means they are using loop diuretics and they are using large volume paracentesis as per required basis. And some of these patients, that is Group B, received midodrine to the dose of about mean of 12.5 milligram. This is not the adequate dose, but still, if they are using 12.5 milligram, let us see what is the results. In this patient, this one is the weight loss is by the standard medical therapy. This is the weight loss which achieved by standard medical therapy, which is significant, but lower than those which are acquired by midodrine. Similarly, the mean arterial pressure also increased more in the midodrine group, and urinary volume also increased more in the midodrine group. What does it mean? It means that the mean arterial pressure is increased in patients who were treated with midodrine. Similar study published from PGI Chandigarh by Dr. Virender, which have used midodrine in patients with refractory and recurrent ascites. So there is a difference between refractory and recurrent ascites. I told refractory, the definition I already told you. When we say recurrent ascites, it means that patient has got more than at least 3 large volume paracentesis in 1 year. So these are the patients who are referred to as recurrent ascites. So in this study, 20 patients were used. 20 patients were randomized to the standard medical therapy, and the 20 were to standard medical therapy along with midodrine. So in this study, they also found that the sodium excretion was more in the midodrine group, which means the renal function increases. Plasma renin decrease, which means that there is an improved systemic circulation, and plasma aldosterone level also decreases, which means that there is a reduced renin activity. What does it suggest? It suggests that midodrine improves hemodynamics in cirrhotic patient with ascites. They followed this patient for about a year, and in 1 year follow-up, significantly more patients in the midodrine group, they achieved complete remission, that is the complete resolution of the ascites, to the tune of about 1/3 of these patients, they achieved complete remission over a period of 1 year. And if you compare to the standard medical therapy, there was a significant difference. So if you add midodrine to standard medical therapy, you can achieve control of refractory ascites in about 1/3 of these patients. And once they followed this patient for a year, they also found that there was significant survival in this patient. So if you can improve the survival of this patient with refractory ascites with midodrine, it is a landmark, I think, important step. But this study has to be validated in other centers and on the randomized control group in a larger way, because they have used only 20 patients. So this conclusion that it improves survival has to be taken with a keynote, but it improves refractory ascites compared to standard medical therapy. So there is an important study which was published in Hepatology long back in 1998. So they have shown that if you give midodrine over a period of about 3 hours, there is a significant increase in the mean arterial pressure. Heart rate also reduced in this patient. Cardiac index also reduced. I must say that why cardiac index reduced? Because it reduces the systemic vascular resistance. So there is another study which have used rifaximin and midodrine, and they have found that if you use combination of these two, it also improves refractory ascites. So midodrine along with standard medical therapy, rifaximin along with midodrine also improves refractory ascites. So what is the hypothesis behind that? Why rifaximin and midodrine? Midodrine is an alpha-1 agonist which improves the splanchnic vasoconstriction, thereby increases the renal flow. Rifaximin, it improves the gut microbiota, thereby reduces the inflammation. Reducing the inflammation also improves the splanchnic vasodilatation. So these two combination of drugs is an important thing which can improve refractory ascites. So this study also showed that midodrine and rifaximin improves the survival as well as the control of refractory ascites. So one important step which all hepatologists and all gastroenterologists know that most of these patients, they have come with refractory ascites for which we need to do a repeated LVP. So along with the large volume paracentesis, we need to give albumin to prevent post circulatory syndrome. That is so these patients, in which this is an important study in which 75 patients were divided into 3 groups. After LVP, patients were given albumin infusion, that is about 6 grams per liter. They were given oral midodrine for 2 days, and the another group was given oral midodrine for 30 days. So let us see what was the response. It was found that oral midodrine, if you give it for 30 days after an LVP, prevent renal dysfunction compared to, like, it is almost equal to the albumin. So you can replace albumin to the midodrine. So this study was also done on smaller subjects. So this study has to be validated in more trials. So, but at least we know from all these studies that mean arterial pressure increase if you use midodrine, cardiac output decreases, systemic vascular resistance increased, urine output and urine sodium increased, and plasma renin activity decreased. And it has got, in majority of the study, has got no renal and hepatic dysfunction. AASLD guidelines has now come up that midodrine can be used in patients with hypotension in patient with cirrhosis, and it can be used in patient who have refractory ascites, though the level of this thing is about level B and class 2A. Just to summarize, midodrine is a potent periphery acting alpha-1 adrenergic receptor agonist. It increases effective arterial blood volume by strengthening vasoconstriction and improves renal flow and GFR. Midodrine can be added to diuretics for elevating the blood pressure of cirrhotic patients in whom the blood pressure falls to less than 90 if you use diuretics. Midodrine alone or in combination with albumin has shown to have better control for the treatment of refractory ascites, and oral midodrine 7.5 milligram TDS in a smaller study has shown to prolong survival over a period of 1 year, and AASLD has now said that it is an effective therapy and can be used in patients who have an refractory ascites. Thank you.
Thank you, Dr. Praveen, for an excellent and lucid presentation on midodrine. I think in one line, if I can summarize, midodrine is an oral terlipressin which improves renal function in refractory ascites. I think we can take questions at the end of the second topic. So both the talks are concluded and then we can have the question answers. Is it okay?
Yes,
so
sir.
the next talk is by Dr. Kunal Das, who is an eminent gastroenterologist in the NCR Delhi, and he has a keen interest in therapeutic endoscopy. And he will be dealing with a very important topic, post-ERCP pancreatitis, which frightens almost every gastroenterologist who is doing ERCP. So Dr. Das will be giving us tips how to prevent this post-ERCP pancreatitis and how to treat if it develops. Dr. Kunal Das, please.
Thank you, sir. And at the outset, I would like to thank Hetero for giving us this opportunity to interact with a large degree of physicians and gastroenterologists who attend this webinar on this important topic of ERCP-induced pancreatitis. Please start the presentation.
Yeah.
Rajinder, can
Yeah,
you
just
to start the presentation, please?
yeah, I'll be sharing the slide, sir. I'll be sharing the slide. Just a minute.
Okay. As the slide is starting, as you know that ERCP is a very therapeutic procedure, and we all know that all therapeutic procedures have a lot of complications. The complications, one of the most dreaded complications and the most commonest complications is ERCP-induced pancreatitis. In ERCP-induced pancreatitis, we know that whenever we are doing the CBD cannulation, sometimes the cannula may go into the PD, and we have now strategies which can reduce this PRCP-induced pancreatitis. Okay, so one of the most important complications is ERCP-induced pancreatitis, and one of the most important strategies is how to prevent it and what is the. My presentation would include some few slides on acute pancreatitis, post-ERCP pancreatitis, what is the newer strategies to decrease pancreatitis after ERCP, and what is the role of indomethacin, and I will share you the clinical data and also give you the clear and clear-cut takeaways. Next slide, please. Next slide.
Yeah, sir.
Okay. So acute pancreatitis is an inflammatory condition of the pancreas caused by an autodigestion of the gland by the digestive enzymes, leading to its functional impairment and morphological change. As we all know, the pancreas is an organ which lies behind the stomach, and any infection or digestion by the pancreatic juices causes pancreatitis. This condition may recur intermittently, and in that case, it can also give rise to chronic pancreatitis. Severe acute pancreatitis may occur up to 25% of the cases. Most of the cases are 60% to 70% are mild pancreatitis, 10 to 15% are moderate pancreatitis, and 10 to 25% may be due to severe pancreatitis, depending. The incidence of acute pancreatitis is higher in USA, Finland, and Scotland. In India, its prevalence is mean age is 45 years, ranging from 26 to 57. Most of the pancreatitis occurs in the range of 30 to 50 years. Next slide, please. Etiology. In the etiology of pancreatitis, main is due to ductal obstructions, acinar cell injuries, defective intracellular transport. Gallstones, alcohol are the most common causes of acute pancreatitis. Uh, Trauma, ischemia, and viruses are other causes. Some of the causes is due to drugs, and one of the minor causes is post ERCP or endoscopic retrograde cholangiography induced pancreatitis. There are certain other causes like hypertriglyceridemia, hereditary, and hypercalcemia also. Next slide, please. So the most important is a diagnostic approach. The diagnosis of acute pancreatitis should be considered in any patient with pain. And if it occurs after ERCP, so another point is about acute pancreatitis after ERCP. So two of the three conditions should be met for a diagnosis of acute pancreatitis. A typical history. A severe acute pain in the upper abdomen which radiating to the back is a typical pain of acute pancreatitis. Elevated serum amylase or lipase, which is more than 3 times from upper limit of normal. Usually, normal range is from 70 to 90 units. So anything more than 300 or 400 would go in favor of acute pancreatitis. Plus, there has to be a imaging, which can be a CT or an MRI or an ultrasound to be consistent with acute pancreatitis. Next slide, please. So out of the three conditions, one is a clinical condition, one is a blood report, and one is an imaging facility. So revised Atlanta classification defines acute pancreatitis. Mild acute is where is no local systemic complications and there is absence of organ failure. Moderate severe acute pancreatitis where there are some local or systemic complications, or there may be a transient organ failure, or both. In severe acute pancreatitis, which is the most dreaded one, there is local or systemic complications, which in the form of low BP or kidney or systemic inflammation, or they may persistent single or multiple organ failures may be there, which is persistent more than 48 hours. That is severe pancreatitis. Severe acute pancreatitis is the most dreaded and also has contains high mortality and morbidity. The definitions according to the classification are: in mild acute pancreatitis, there is no pancreatic or pancreatic necrosis. In moderate, there may be some sterile or peripancreatic necrosis, and there is a transient organ failure of less than 48 hours. Whereas moderately severe, there may be some infected pancreatic or peripancreatic necrosis, and the organ failure is persistent more than 48 hours. And lastly, there is a severe acute pancreatitis where there is infected pancreatic necrosis or a peripancreatic necrosis with persistent organ failure more than 48 hours. This pancreatic necrosis is usually seen on CT scan, which is done after 48 hours of the abdominal pain. Next slide, please. This is the local complications which can see. This is the acute pancreatitis where there is acute fluid collection. There may be some acute necrotizing pancreatitis which is less than 4 weeks. This is a pseudocyst formation which is formed due to formation of acute fluid collection going into more than 4 weeks. And here we can see a wall of necrosis with less of fluid but more of pancreatic necrosis which is more than 4 weeks. Next slide, please. So coming to our topic of today, which is ERCP, ERCP-induced pancreatitis. First, I would like to tell you what is ERCP. ERCP is a endoscopic retrograde cholangiopancreatography. It is a simple test which a flexible tube goes to the mouth and reaches the bile duct, which is this, and it is a thing either diagnostic or therapeutic purpose, either due to some stones, or it may be due to bile duct cancer for diagnosis, or it may be for some treatment or putting a stent. So even if a complicated therapeutic modality is the most common and specialized procedure to be used in the diagnosis and treatment of pancreatic and biliary system disorders. Advantage compared to surgery is limited trauma and simplicity of operation and short recovery time. Next slide, please. So the patient population which requires ERCP is usually when bile duct or pancreatic ducts have become narrowed or blocked because of gallstones that form in the gallbladder and then shift to the common bile duct. There may be some infection. Acute or chronic pancreatitis may be present if there is a ductal rupture due to either trauma or due to any disrupted duct syndrome in pancreatitis. Trauma or surgical complication, bile ducts or pancreatic ducts, pancreatic pseudocyst, and tumors or cancers of the bile duct and pancreas are the most common indications for ERC. Next slide, please. So what are the risks which are related to ERCP? The most commonest risk is pancreatitis, which can occur in up to 2 to 15%, depending upon the type of patient population, the type of operator, and the clinical situation involved. The other risk of ERCP are cholangitis, perforation, hemorrhage very rarely, cholecystitis, asymptomatic hyperemesis, which is very common, aspiration, hypoxia, bleeding, and sepsis. In very less number of cases, it can also cause death. Next slide, please. Now, coming to our topic of post-ERCP pancreatitis, PEP is the most commonest complication of ERCP and is a crucial factor in morbidity and mortality. Chemical, mechanical, enzymatic, and hydrostatic kernel causes are due to as pathophysiology of PEP. Development of PEP is thought to be based on pro-inflammatory cascade causing pancreatic acinar cell injury that induces systemic cytokine release. The economic and social impact of PEP is substantial. Predicting pancreatitis after ERCP can be difficult. Next slide, please. So there are certain standard consensus definition of PEP. The earliest definition was by Cotton and Lehman in the early 80s was pancreatitis after ERCP is a clinical illness with typical pain associated with at least threefold increase in serum amylase or lipase at 24 hours, with symptoms impressive enough to require admission to the hospital for treatment of extension of an existing or planned admission. Further, after in 1990s, when the Atlanta criteria had come, the definition of PEP was proposed by Banks and Bolin as follows. The diagnosis of acute pancreatitis requires two of the three features. Abdominal pain, which is consistent with acute pancreatitis, which is acute in onset, persistent, severe, epigastric, and often radiates to back. Increased serum lipase or amylase activity, which is at least 3 times of upper limit of normal, and characteristic findings of acute pancreatitis on CT or MRI or even ultrasound. Next slide, please. So, so these are the standard definitions of PEP that post procedure, if there is a pain which is consistent with acute pancreatitis, raised amylase or lipase levels, and a imaging facility which can be ultrasound or CT or an MRI will be confirmed as post ERCP pancreatitis. Incidence of there was a study which saw around 1,000 patients. It was found that most criteria between US and Indian centers were almost similar. Difficult cannulation, failed cannulation, pancreatic sphincterotomy was more among cause of PEP among US. Precut sphincterotomy was more common in India. More than 2 duct injections was again more common in India as a in US as a cause of PEP. Incidence of PEP was almost similar in Indian center as well as US center. And duration of hospitalization was 2.2 days compared to 4.4 days in US, less in India. Next slide, please. So what are the patient related? There are various risk factors for PEP. One are the patient related risk factors and one is the technology or condition related factors. The patient related factors of PEP which are increased possibility is young age, female gender, suspected sphincter of Oddi dysfunction, recurrent pancreatitis, any absence of chronic pancreatitis, history of previous post-ERCP pancreatitis increases the risk of another episode of post-ERCP pancreatitis. Possible are absence of CBD stone, normal serum bilirubin, periampular diverticulum are possible risk factors of PEP which are not confirmed. There are certain things which are absolutely not related to PEP are normal or small CBD diameter, presence of pancreatic divisum, allergy to contrast medium. These are not patient factors for PEP. Next slide, please. So how to prevent PEP? So there are six main fields according to Chion et al. In 2013. The prevention of inflammatory cascade, facilitation of cannulation, relief of sphincter of aortic spasm, inhibition of intra-acinar tryptogen activation, and decrease of pancreatic enzyme secretion. These are the main fields where you work on for prevention of PEP. Next slide, please. So, what are the current? A lot of new methods and new are there. New strategies have been in the last 2 decades have evolved, which have reduced the incidence of PEP. The most important is the rectal or indomethacin or difluprednate use before the start of ERCP, pancreatic stent placement, hydration, spray of epinephrine, and in certain countries, especially Chinese, raw rupav have been found to be useful in decreasing the incidence of PEP. Next slide, please. So this is the landmark trial by Elmuzer et al. In 2012 in NEGM, where he conducted a randomized trial of rectal indomethacin to prevent post-ERCP pancreatitis. In this study, a total of 602 patients were enrolled and followed up. Majority of the patients, 82%, had a clinical suspicion of SOD. Post-ERCP pancreatitis developed in only 9.2% in the indomethacin group, and 27 out of 295 patients. Whereas in the placebo group, which did not get rectal indomethacin, it developed 16.9% of the patients. As we know that this group of sphincter of aortic dysfunction are mostly in younger females and have a more who have a higher incidence and risk of PEP. So in that higher risk of PEP, rectal indomethacin was significantly reduced the incidence of pancreatitis. Moderate to severe pancreatitis developed in only 13 patients in indomethacin group, while it developed in almost double percentage in 8.8% in the placebo group. So the authors concluded that among the patients at high risk of post-ERCP pancreatitis, rectal indomethacin significantly reduced the incidence of this condition. Next slide, please. So now, what are suppositories? Suppositories is a medicated or a solid dose form which is intended for insertion of body orifice where they melt, soften, dissolve, and exert localized and systemic effects. The medicament is incorporated into the oil bases which melts at the body temperature or into the water-soluble or miscible base which further dissolves in the mucous secretions. The advantage of a PG base is that they are chemically inert, inserted, not irritant, doesn't allow any bacterial growth, and physical properties change with molecular weight, have prolonged action, and suppositories are clean and smooth in appearance. Next slide, please. So, what is the concept? The suppositories get absorbed from the middle and the inferior hemorrhoidal veins directly into the systemic circulation. Drugs avoid stomach, digestive enzymes of the stomach, and the first pass metabolism in the liver. Suppository, however, it must be careful that the suppositories, if placed too high, are absorbed by the upper hemorrhoidal vein and then it drains into the portal vein flowing into the liver. So that is the risk. So we must be careful that the suppositories are inserted not too high, but in the middle and the lower portions. Next slide, please. So factors which influence the rectal drug absorption are the colonic content, circulation mode, pH, lack of buffering, motility of rectal wall, quantity of the rectal mucus, and properties of the rectal mucus. It was maybe there. Next slide, please. So what is indomethacin? Indomethacin is a non-steroidal anti-inflammatory agent with analgesic properties. When given as a single dose, it is inexpensive, easily administered, and has a favorable risk factor. So it gets absorbed. Phospholipase A2 and this NSH block this COX-1 COX-2 inhibitor and prevents the conversion of arachidonic acid into phospholipase B2. Thus, the tissue-specific isomerases, the prostacyclins, thromboxane, and prostaglandins, and E2 and E alpha are prevented from synthesizing, and it is provides an attractive option for prevention of post-ERCP pancreatitis. Next slide, please. So as NSAIDs, there are many. Even rectal diclofenac has also been used and has been found to be useful. In fact, till the time indomethacin rectal was not being available, we were using rectal diclofenac only, and we found to be useful. Comparative study of indomethacin, diclofenac, or naproxen for the prevention of ERCPs, and we can see that primary outcome measured by development pancreatitis, diclofenac and indomethacin patient groups had lower incidence PEP compared to the naproxen group. So rectal indomethacin or diclofenac is recommended for the prevention of PEP. Next slide, please. So almost 8 trials have been utilized where rectal endomethacin has been shown to prevent moderate to severe PEP and death and should be used before the procedure. 8 trials have been published between 2007 and 2016, almost an experience of 3,300, more than 3,300 patients. All trials use relatively similar criteria to define PEP. All included studies use 100 mg rectal indomethacin. As you can see, right from there, many studies from Iran, Hungary, Mexico, USA, many studies from USA. Almost all the studies have more than 500 patients. Next slide, please. So the high risk patients, we can see this graph. The most of the studies have found both in high risk category of patients, in moderate to severe post ERCP pancreatitis, in pre-procedural and rectal indomethacin, in SOD patients, and this is all patients. We can see that this diamond is more on the odds ratio is more on the side of using rectal indomethacin benefiting patients. So the pool proportions estimates that the rectal indomethacin it was 5.6 and placebo 8.8. The rate of PP was significantly lower with rectal indomethacin compared to placebo. Next slide, please. So the meta-analysis suggested that rectal indomethacin is effective in patients to prevent PEP. It prevents PEP both in specifically more in high-risk patient groups, effective in those with sphincter of Oddi dyskinesias, significantly decreases the rate of moderate to severe PEP and death in all patients. Rectal indomethacin should be given to all patients without contraindication prior to ERCP. The important point is it should be given before the start of ERCP, not during or after ERCP. Most of the studies have found that the benefit of rectal indomethacin starts if you give before the ERCP. Next slide, please. This is a review article by Zinahi. Rectal indomethacin is a protective against pancreatitis after ERCP. Systemic review and meta-analysis, where they studied around almost more than 6,000 patients who underwent ERCP, with 459 patients present in PEP. There are 10 Ascites evaluated 100 mg of rectal indomethacin suppository, and we found that meta-analysis found that the prevention of PEP with rectal indomethacin seen in only 5% of the patients PEP was found, whereas in the in the control group, 13.66% of the patients were having PEP. So having the risk of ratio is 0.63. Rectal indomethacin significantly decreased the PEP risk among high to average risk population undergoing ERCP. Therefore, rectal indomethacin seemed to be an ideal and appealing PEP option considering the ease of administration, cost effectiveness, and safety. Next slide, please. So there was another study around November 2012, which during diagnosis of PEP and 4.7%, reduction in incidence was almost to the extent of 55%. Reduction in PEP was almost 62%. RI reduced PEP in consecutive as well as low risk patients. RI should be rectal indomethacin should be administered in consecutive patients unless contraindicated. So this study evaluated the role of rectal indomethacin in low risk patients, and in them also it was found to be very useful. in addition to the high risk groups that other studies have studied. Next slide, please. Therefore, the ESGE guidelines, the European Society of GI Endoscopy guidelines, they recommend that routine rectal administration of 100 mg of diclofenac or indomethacin immediately before ERCPs in all patients without contraindications to non-steroidal anti-inflammatory drug in strong recommendation and moderated quality evidence. Next slide, please. So, other than the rectal indomethacin, what are the other strategies to prevent PEP? First is the pancreatic stent placement across the pancreatic stent placement. Pancreatic stent placement across the pancreatic sphincter may maintain the flow of pancreatic secretions, which may be interrupted through pancreatic papillary edema and therefore control to reduction of PEP. This was by Guda et al. 2015. They found that whenever in our strategy also is that second if the pancreatic cannulation is done second time, we put in a pancreatic stent. That is very important, and we put in a 5 French stent, and that has been found to be useful in prevention of PEP. It reduces the pancreatic edema, and the stent usually falls off within 7 days. The next strategy we used is hydration. As you know that in acute pancreatitis also, hydration is a very important component. Wu et al. Showed that hydration by lactated ringer solution may reduce the risk of systemic inflammatory response syndrome. 3 cc per kg per hour, 8 hours before and after ERCP, and 20 cc per kg bolus during ERCP reduce the risk of PEP to 0 compared to 17% in among the controls. Another useful technique is spray of epinephrine. Application of epinephrine to the papilla is considered to mitigate the edema, contribute to vascular permeability, relieve the muscles of sphincter of Oddi and the musculature of the duodenum, thus preventing the increased pressure on pancreatic duct and stopped activation of pancreatic enzymes and the drainage of pancreatic fluid. This is also a simple technique where at the end of the procedure of ERCP, using the cannula, you just spray almost 5 to 10 ml of 1 is to 10,000 epinephrine, and that reduces the incidence of PEP. In our center at Manipal, we use all the 4 strategies to reduce the incidence of PEP. We use a good hydration level before starting the ERCP, and we put the patient on a rectal indomethacin or diclofenac before the start of ERCP, and then just on the table. If there is a if the PD is cannulated twice, we put in a stent, and and then at the end of the procedure we do a spray of epinephrine before completing. This all has reduced dramatically reduced the incidence of PEP from almost 5 to 7% in to almost 1 to 2%. Rarely we have these days now any cause of PEP in our institute, because of the institution of these 3 very useful and easy to do strategies. There is another study from China which has there is a herb, traditional Chinese medicine raw rupa, which has been used. They say it has this traditional Chinese medicine rupa has some special qualities to relieve clinical symptoms, prevent production of inflammatory mediators and cytokines and bacterial transformation, and mitigate abnormal compartment syndrome. So after the completion of ERCP, they give this into some liquid to drink, and that reduces the PEP incidence. Next slide, please. Because of the nature of PEP, which is such an important complication, there have been many strategies which have not been found to be useful for PEP. The ones which I will describe are use of intraduodenal acetic acid, nitroglycerin plus glucagon, ketoprofen, Eudonafil plus acinofex, somatostatin, diclofenac IM, unfortunately is not useful, nefastromat mesylate, allopurinol, secreting, platelet activating factor IL-8, IL-10 has not been found to be useful in preventing of PEP. Techniques like wire guided cannulation and NKP have also not been useful in the found to be useful to reduce the incidence of PEP. Next slide, please. So algorithm for prophylaxis PEP is any contraindication for NSAIDs. If there are none, then you should use rectal indomethacin or diclofenac. And standard convolution or difficult convolution without easy pancreatic stenting, no further intervention. If there is a difficult cannulation, then we should put in a pancreatic stent. If there is contraindication to NSAIDs, so high volume hydration, this should be very concerned, especially if patients have some cardiac disease or renal disease. So start, if they do not have any contraindication, then you can start ringer lactate, continue hydration. If there is a difficult cannulation, then pancreatic stent should be used. If there is any connection to high volume dilation, then try to use sublingual glycerin nitrate and consider a pancreatic stent. Next slide, please. So, what are the key takeaway pointers? Rectal indomethacin is effective in preventing of post-ERCP pancreatitis in high and moderate risk patients. It significantly decreases the rate of moderate to severe PEP and death in all the patients. It provides a strong evidence for current guidelines in clinical practice. RI is effective, rectal indomethacin is effective in preventing of PEP in patients even with low risk of PEP. Therefore, in my opinion, rectal indomethacin should be given to all patients without a contraindication prior to ERCP, and rectal indomethacin is an ideal and appealing option PEP, to prevent PEP because of ease of administration, cost effectiveness, and safety. Next slide, please. So I thank you. I come to this is the end of my presentation, and I thank you for all the people who have listened to me, and I am happy to answer any of the queries and questions.
Thank you, Dr. Kunal, for an excellent presentation on post-ERCP pancreatitis and strategies to prevent this post-ERCP pancreatitis. I think we have a couple of minutes to have question and answer. So before I see in the chat box, let me ask first question to Dr. Praveen Sharma. Dr. Praveen, you said midodrine in diseases where HVPG is more than 5 millimeters of mercury, and the effective portal hypertension, which leads to decompensation, is more than 10 millimeters of HVPG of more than 10 millimeters of mercury. Do you think that is there any role for midodrine to prevent this before decompensation? Can you use it when the HVPG is less than 10 and more than 5, so that it doesn't increase to the level of 10 and you did not allow the decompensation to happen? So is there any role of midodrine in preventing the decompensation?
So this is an interesting question, but unfortunately there are no such studies which has shown that prophylactically you can use midodrine for the prevention of ascites. You know, there are many previous studies which have been used for the prevention of increase in the portal pressure, like with beta blockers. So, but unfortunately, most of the studies are they're not convincing. You can prevent increase in the portal pressure either by using beta blockers or by using carvedilol. So I don't think midodrine will help in that case. You can prevent formation of ascites with midodrine, but still it has to be answered with some studies.
Okay. The next question, Dr. Praveen, is once you have used the midodrine and patient the ascites has disappeared, when do you plan to stop midodrine? Do you continue with midodrine, or is there any exit plan for the midodrine?
So till now, most of the studies which have used midodrine, they are up to 1 year. And okay, and most of the studies have shown that the response rate, that is a complete response, that is the ascites has disappeared in 2 studies which are done so far, is about 20 to 30%. In but my feeling is that if you have used midodrine, I think it has to be continued, because you cannot reverse the splanchnic vasodilatation by stopping it, because the process is still there, cirrhosis is still there, and by midodrine you are not reducing the portal pressure. So if midodrine is being used for the control of refractory ascites, it has to be used till the patient underwent liver transplant. If there is no other option, I think you continue with the midodrine.
But unfortunately, the problem is the cost.
Yes, sir.
If you continue for 1 year, then the cost is huge. And even if you don't, if the ascites has disappeared or ascites has decreased, they will continue with your other diuretics and will stop the midodrine completely.
That,
Because
I totally agree. The cost is an issue, but if the patient has developed refractory ascites, patient will live for at least 1 year or 2 years is very unlikely. So that is a different scenario. So I think
yes.
whenever you use it till his end, whether he underwent a liver transplantation or his death.
Okay, okay. Dr. Kunal, I have a simple question that in your practice, because you are doing so much of ERCPs, despite having all these measures, what percentage of your patient remains admitted with mild pain suggestive of pancreatitis after the ERCP for more than 24 hours?
In my opinion, in my center, where we are using all the three procedures, pancreatic, namely pancreatic stenting, epinephrine spray, as well as indomethacin, we have dramatically reduced. I think only, I would say, 1 or 2% of the patients of pancreatitis, post ERCP pancreatitis, are admitted in the hospital. It has dramatically reduced. Most of the times they do not require admission. Some amount of pain may be there, and some amount of hyperamycemia may be there. But if I say of ERCP-induced pancreatitis requiring admission, I think it has reduced to almost 1 to 2% only.
Okay. And other than these three majors, do you look at the other factors? So patients are comorbid, the diabetes, hypertension, elderly, where some of these patients may have respiratory problems like carpulmonale or respiratory insufficiency, where these non-steroidal anti-inflammatory drugs may not be permitted by the general condition of the patient. Is there a difference between these two groups, whether those who cannot receive non-steroidal anti-inflammatory drug versus those who receive non-steroidal anti-inflammatory drug? Do you think that there is a difference, or the pancreatic stenting alone is sufficient in this particular group?
Well, so there are very few indications where we have, because it is a single dose, it is not a repeated dose, it is a single dose of rectal indomethacin. So there are very few indications where contraindications to this thing. If it is not to be required, only if the patient is highly plasmopathic or it is allergic to a non-steroidal anti-inflammatory drug, there is a specific incidence, then it should not be done. Normally, we have found, I think in the whole last 2 years, we have only one patient where we couldn't use because of this indication. Otherwise, in all the other patients, we are able to use. Even in patients who are cardiac patients or nephro patients. In nephro patients, sometimes it is a problem because of the kidney failure. But we do give the same to the patient, because post-ERCP pancreatitis, if it occurs, then it will be doubly problematic for that patient. On the other hand, the hydration is one which is more important, especially among kidney failure patients and cardiac patients, that we cannot give that high amount of lactating ringer lactate, although it's ringer lactate. So there we might have to forego this hydration part. But in most of the times, rectal indomethacin we have been able to use. Just
And
we take the consent. If there is any kidney issue or something, we take the consent. And most of the times we tell that the advantages score over the disadvantages, because it is a single episode and you don't have to take it also. It is only in the rectal form that you have to take
okay.
it.
And how early you start the hydration before ERCP? 4 hours, 6 hours?
Usually we call our patients almost 3 to 4 hours before the ERCP, and then we start the hydration part, continue, and after because in India we are doing more of daycare procedures, so patients who are admitted procedures, we can do the hydration 8 hours before the ERCP and 8 hours after the ERCP. But in where we are doing most of the daycare procedures, so that much of time is not possible. So we try to do 4 hours before the procedure, and after the procedure we give 2 hours. That is usually enough. We have not found that it requires that 8 hours is a bit on a higher side. But we do give a good amount of hydration.
Okay. Are there any questions in the chat box, Mr. Rajendra?
No, it's with you. I think I don't think so. There's any question right now.
Yes, I have received a few questions which I will take up one by one.
Okay.
First question is what would be the ideal time to check amylase and lipase if there is pain? So any patient of ERCP who undergoes a pain in the severe pain requiring oral or IV analgesics should get an immediate amylase or lipase done. The diagnosis of post-ERCP pancreatitis is that amylase lipase should be increased within the next 24 hours of the procedure. So that's what we ask the patient to get the immediate amylase lipase done. That's how we diagnose post-ERCP pancreatitis. Then there is one question from Mr. Sandeep, Dr. Sandeep, why indomethacin is always more preferred choice of NSAIDs? There is no hard and fast choice. We have found by literature that both rectal indomethacin and rectal diclofenac have been utilized for this condition. I'm not very sure, but I think this indomethacin and diclofenac rectal formation have come from the rheumatoid arthritis group where it was being used instead of to prevent gastritis perhaps because rectal indomethacin helps gets an arterial circulation goes into the arterial circulation and is more effective. But the evidence today is only with rectal indomethacin or rectal diclofenac. So we have to use any of these two which are available in your center. Then there is another question from Dr. Avinav that there are multiple range of hydration, but which one we should prefer? So the evidence in literature is that we have to prefer ringer lactate solutions only because too much of normal saline has not been found to be effective. In fact, that much of normal saline was given into the control group, but only ringer lactate was effective. The reason which is given is because that increase in acidity or in intra arterial acidity it decreases the trypsin decreases activation of trypsin, and that's how it decreases the post ERCP pancreatitis. Okay, and the fourth question is from Dr. Prashant. He says that ESGE recommends 100 milligram of indomethacin pre-ERCP, but few are still preferred IM route. In this case, what should be better choice and now? See, the evidence of post-ERCP pancreatitis prevention is only with rectal indomethacin. Still, the jury is out why only rectal indomethacin is useful and why not IM diclofenac or IM or rectal diclofenac. We don't know still, but evidence-based medicine suggests only rectal formulation is useful for prevention of PEP, not the IM formulation. So still, based on this, I will only prefer the rectal form of indomethacin for prevention of post-ERCP pancreatitis.
Dr. Ajay? I
Yeah,
think in my chat box there are few questions.
yeah,
I think
please
it is
go
a
ahead.
direct
Yes,
business,
yes,
no?
yes.
So
I think
one
there is,
question,
yeah,
I think
what
they
are
have
the side
directly,
effects of midodrine for long-term use?
they have directly communicated to me probably.
Yes,
So
yes, yes.
first question is from Dr. Shriram. When patient is under treatment of midodrine, can we completely discontinue LVP? So midodrine only helps in mobilization and you can use diuretics in a better way if you use midodrine. So you cannot completely discontinue LVP in most of the patients. About 20% of the patient, they respond completely, but 80% of the patient, you will require still LVP, but the interval will be slightly more. This is what is my clinical practice. So you can't discontinue with the LVP completely in these patients. The second question is from Dr. Sandeep. What is the maximum dose of midodrine in clinical practice? So Dr. Ajay has truly said that the dose of the midodrine depends upon how much the patient can afford. That is the problem. But so the ideal dose should be, you should try to increase the mean arterial pressure to at least 10 millimeter of mercury. In some patients, this can be achieved by 5 milligram 3 times, that is the 15 milligram. Sometimes you can achieve it 10 milligram. So that depends upon, the patient to patient. It is not like that there is a standard dose of midodrine that you should use 20 milligram in a day, or you should use whatever amount. But in case the patient is affordable and patient can say, okay, I can afford anything, then probably 15 milligram in a, like 3 times in a day is the maximum dose which I have used. So this is the maximum one. So, but depends upon how much the patient can afford. most of our patient and most of the doctor, they use 2.5 milligram because this is the commonly used in the tablet form. 2.5 milligram TDS, and we think that probably the patient is being responded. This is not the scenario. This is a very low dose. So ideally, one should try to target the mean arterial pressures to more than 5 to 10 millimeter of mercury to baseline. That is the ideal scenario. Third one is, this is again for the hetero people. I think if you can cut down the cost of the midodrine, I think most of the people can afford it. Third is from Dr. Sandeep, but is that is okay. One is from Dr. Rajdeep. Can we completely reduce sodium intake from the diet of ascitic patient? Ideally, this is not possible. If we completely avoid sodium, this has become unpalatable, and most of the Indian people will not take diet at all. The basic principle is nutritional. Patient should take a good nutrition. Even if he wants to take a little bit of more salt and he can take that diet in a better way, I think it is allowed from my point of view, and completely abstinence of sodium is not possible in Indian scenario. Fourth question is from Dr. Prashant. What is the treatment duration of midodrine in HRS and ascites? If the patient has developed HRS, most of the studies has shown that midodrine is though effective, but it is inferior to the terlipressin. So the patient has developed AKI HRS, terlipressin should be used if it is available along with albumin. But for the treatment of HRS, midodrine should be avoided because it has not shown to have good quality results. But in case the terlipressin is not available or there are some other scenarios, midodrine can be used along with octreotide and albumin for the treatment of HRS to a period of about 10 to 15 days. If there is no response, better avoid midodrine in this scenario. Can we prescribe midodrine in hepatic encephalopathy? There is no such data. It is better to avoid if we do not have any data on in patient with hepatic encephalopathy. Then the question, this is from Dr. Anil, which have asked this question, can we prescribe midodrine? And the other one is from Dr. Prashant. The question from other doctor is Dr. Santosh. What are the side effects of midodrine for long-term use? So normally, midodrine has got no much definite side effects, but goosebumps are the common things which I have seen in my clinical practice, that patient says that they have, they feel like they have goosebumps. Sometimes they said they have urinary problem. These are the common side effects which are there in patient in whom you put midodrine on long terms. But try to avoid giving midodrine at the bedtime. Normally we write down midodrine 3 times a day. So sometimes the patient take before sleep. This should be avoided because it can cause sometimes, supine hypertension, which can create sometimes some problems. So I think these are the questions in my chat box.
Okay, I think there are no more questions in my chat box. Dr. Kunal, do you have any questions in your chat box?
No, I have no, but I have one question for Dr. Parveen. Are there
Okay.
any contraindication to use of midodrine in any of the patients?
If you ask that if the patient has got apparent AKI, and patient has, if this is not, this should be avoided because there is no such data in such patients. If the patient is in an overt encephalopathy, if the patient has an obvious GI bleed, if the patient, so these are the apparent contraindications you should not use because there is no data. As such, I don't find there is any apparent contraindication of using midodrine in cirrhotic patients. You can use it, but it is not approved. I must say that though there are certain guidelines, but it is not yet approved. Midodrine is a prodrug which gets converted into the active form in the liver. So how much dose should be used, how much its effect on liver is still debated. But there are such off-label use, so we can continue to use.
Okay, if there are no more questions, I thank you, Dr. Praveen and Dr. Kunal, for an excellent presentation on 2 very common topics which are relevant for our day-to-day clinical practice. And it's my privilege to thank Hetero to bring these 2 common talks on the platform for discussion among the gastroenterologists. I'm sure all of us are benefited and all of us will have better understanding of these 2 conditions while dealing with these kind of patients. With these words, I once again thank you, Hetero. I thank you, Dr. Praveen and Dr. Kunal, for an excellent presentation. Over to Mr. Rajendra.
So thank you very much. So thank you very much for this deliberation. One thing I think midodrine cost was discussed, which I would definitely like to highlight. Uh, Initially, once we discussed with the doctors, there were two issues doctors were facing or patients were facing. One is there are availability of packing, like 10, 20, and 100 tablet packing were available in market, and the cost was running around 70 to 90 rupees per tablet. So it was not easy for patient to afford a pack of 100 tablets at once in a. So that we have taken care of that two things. We have reduced price of 48 rupees now per tablet, but most important is packing is 10 into 10. So it's easy for a patient to purchase stick one or two or three based on his pocket. So this is the things which we have changed in case of Midohep, which is a brand of hetero. So that is, I think, I'm supposed to discuss this point because I think cost was one of the factor which was discussed in Dr. Praveen Sharma's presentation, sir. Anything, sir, from your side, Dr. Kunal?
Yeah, so in fact, we are very happy that Hetero has brought this product. We were searching for this product for a long time. In fact, we started using rectal diagnostic almost 2 years ago, and because the evidence was there with indomethacin, and we are very thankful to Hetero that it has brought this product. It's a niche product, but it is very well appreciated by the persons, by the doctors or endoscopists who are doing ERCP, that this helps us to really bring down the PEP in all cases, and this is backed by solid evidence in the literature. I thank you, Hetero, for inviting me as well as to launch these products in the such a useful and necessary products for our patients. Thank
Thank
you.
you, sir. Thank you very much, sir. Dr. Praveen, anything to say, sir?
I think Dr. Ajay and me have already told you that probably your drug midodrine can be used in a wider way if you just cut down the cost. That is the only thing which I can say.
I understand.
I'm telling you that most of the people, most of the gastroenterologists, they want to use midodrine, but 90% of our patients, they're not able to afford this for the long term.
Absolutely.
You
Understood.
better understand.
So well taken, sir. Point well taken. Ajay, sir. Anything there, sir? So, sir. Thank you very much, sir. I take this opportunity to thank Dr. Ajay Kumar Jain for running this show so nicely. Thank you, Dr. Kunal Das, sir, and Dr. Praveen Sharma, sir, for such a great deliberation. I'm quite sure this elevated session taken by our eminent panelist has helped us to boost our knowledge on discussed topics like role of midodrine in refractory ascites and role of endomethacin in ERCP-induced pancreatitis. I would also like to thank audience for taking out time from their busy schedule. Last but not the least, I would like to thank Hetero team, especially Nehru sir, our marketing team, Ms. Lakshmi, Akshay Ajare, and Aditi for supporting us to organize this program, sir. Thank you very much. We'll definitely make another attempt to this program. Another program will definitely arrange, sir. Right, sir. Thank you very much.
Okay.
Bye, thank you. Thank you, sir. Thank you.
Bye.
Okay, sir. Bye, sir. Bye.